This webcast and any accompanying materials are copyrighted by the American Association for Respiratory Care. Any public display, sale, copy, or distribution of the video or materials may only be undertaken with the prior written consent of the AARC. Copyright 2014, all rights reserved. My name is Doug Lair. I am a registered respiratory therapist and an associate executive director at the AARC. I welcome you to today's presentation, The Role of Ethical Decision-Making in Multifaceted Emergencies.
This webcast is sponsored in part by an unrestricted educational grant from Draeger. The 2014 Frost & Sullivan Best Practices Award in Global Mechanical Ventilation, Equipment Growth, Excellence, Leadership.
Thank you, Reagan. Upon completion of this AARC webcast, participants will be able to 1. Define ethics and morality, 2. Discuss ethical dilemmas and moral agreement, 3. Identify various situations in which ethical decision-making is challenged, and identify various models of decision-making for emergency situations. I am pleased to welcome Dr. Shawna Strickland. Dr. Strickland is a registered respiratory therapist herself, a neonatal pediatric specialist, asthma educator, and associate executive director at the AARC. She earned her graduate degrees in education at the University of Missouri St. Louis and a graduate certificate in health ethics from the University of Missouri in Columbia. Neither Shawna nor I have conflicts of interest related to this presentation. Any use of images or brand names is not in any way meant to be an endorsement of a specific product, but to merely illustrate a point of emphasis. With that, I will welcome Shawna Strickland to the program.
Thank you very much, Doug. I appreciate that. And I'm glad that you all joined us today for this topic. It's a little bit of an interesting topic because we're totally changing how we are looking at this, at patient care and the allocation of patient care. So when we talked about the objectives, I want to first start off by getting us all on the same page and defining a few things just to make sure that we're all talking about the same issue. And then we'll go into the actual dilemmas and such. So when we talk about morality and ethics, it's important to understand that these are not synonyms. They don't mean the same things. There are some significant differences between the two. Something also to consider before I get into these definitions is when we talk about American society, we're talking about levels of acceptable behavior. The law is the minimum acceptable behavior in the American society, so things that are legal, of course, and things that are illegal. But ethics, on the other hand, is the highest standard of behavior in society, so that there are things that are legal that may not be ethical, depending on your perspective. So morality in and of itself is a shared belief about right and wrong conduct in a culture or society. And depending on the culture or the society, you and I could have multiple contexts for this. So we have our shared society belief, shared societal beliefs within the context of our country, our city, our county, our smaller community. We have shared beliefs about right and wrong within the respiratory therapy culture. So these are beliefs that bind the people together within that society. Ethics, on the other hand, is the analysis of those shared beliefs. So an example, and those shared beliefs may not be held by everyone within that group, but as an example, homicide is illegal in American society, and it's accepted by the majority of American society as an immoral act. However, cheating on a spouse is not an illegal act, but may be perceived as immoral or unethical depending on your social group. So it's important to understand that morality is what we feel. Ethics is the analysis of that context. When we're analyzing these situations, we want to make sure that we are not collapsing all of these moral dilemmas into an easier question. If these were easy questions, we could get onto a webcast and talk about what to do in certain situations. That's the problem with these dilemmas. They provide multiple paths that may or may not result in an ethically acceptable outcome, and we have to decide which of those paths are appropriate. So it's easy to try to reason through the situation in the context of medicine or law. For example, when I was teaching ethics to undergraduate students, I would give a situation to those students. There were, the situation they received had 7 very critically ill patients. The patients were of differing ages, differing backgrounds, different socioeconomic groups, different disease processes. And within that context, I also told them they only had 3 mechanical ventilators for these 7 patients who desperately needed to have mechanical ventilation. What they really wanted to do, it was a multidisciplinary course, but what the respiratory therapy students really wanted to do was to completely reject my notion that I had 7 patients who needed mechanical ventilation and only 3 ventilators. They wanted to come up with a clinical solution. Let's use my non-invasive ventilators. Let's use transport ventilators. Let's go to another facility. Let's go to the other facility. The experienced respiratory therapist would actually ask me for a PR2. So anybody out there remember a PR2 for mechanical ventilation? If you can, raise your hand there. There are a couple of them out there that remember using a PR2 for mechanical ventilation. But the core issue I wanted to discuss was not, can you mechanically ventilate this patient with something else? The question was, I have several patients who need mechanical ventilation with only 3 ventilators. How am I going to allocate that scarce resource? Because the resources is the issue here. How do you ration life-saving equipment? So note that we're not trying to generalize our expertise, because of course we have expertise, but we can't solve an ethical issue with a clinical response. And we're not divorcing morality from this, or our ethics from this clinical reasoning. The ethics and the clinical piece are grounded in evidence. The morality is how we feel about that. And quite frankly, this is what's going to provide us a lot of barrier, a lot of limitation as we try to move into some sort of moral agreement. So I have a huge list here of barriers to moral agreement. And the point here is we're not always going to agree on a situation. Has anyone in the last 12 months had a disagreement on a clinical topic with a physician? If you have, raise your hand. Of course we have. I have clinical disagreements with physicians and with respiratory therapists and with nurses. Of course we have. But we also have disagreements on what's the ethical thing to do in those situations. So we have a few issues that we're looking at with regards to barriers, but the different sets of beliefs can be a huge, huge barrier. We see this with culture, we see this with religion. For example, several years ago, there was a case of a young man. His name was Danny Hauser. This was in the news, 4 or 5 years ago, I guess. And Danny was of a newer religion, a religion that had very specific sets of boundaries for medical therapy. And one of those is that his parents wanted him to not have chemotherapy for a cancer that he had received. So what happens when we have a group or a patient whose belief sets significantly differ from our own? Are they right? Are we right? How are we going to get to that moral agreement? And this is going to cause a lot of angst amongst the team. The next one I want to talk about is a little bit lower on the list, defining futility. Medical futility can be a very, very difficult concept. Futility, medically futile treatment means that to a reasonable degree of medical certainty, that's the key here, a reasonable degree of medical certainty, it is not possible for the proposed intervention to act as a bridge to A, prevent or reduce the deterioration of the health of an individual, B, prevent the impending death of an individual, or C, effectively or appreciably alter the course of a disease. Futile treatment is identified as treatment that is burdensome and harmful to the patient. We accept that chemotherapy is a beneficial treatment for cancer. Could we also accept that it could be also a futile, burdensome medical procedure as well? The other thing I want to talk about on this page specifically is about inflated expectations, and I know that you have all experienced this at some point. Has anyone out here watched medical television? Raise your hand if you've watched House or Grey's Anatomy, or I'm going to show my age here, ER. St. Elsewhere, it's one of my favorites. How often are those facilities successful in CPR? It's interesting that the television medical shows are wildly successful when they initiate CPR, right? There was a Respiratory Care Journal article in 2010 by Thigpen and group, and they identified that the survival rate to discharge of a witnessed cardiac event resulting in CPR is 17%. Survival rate to discharge of in-hospital CPR, 17%. What's interesting is that in 2000, a group studied perceptions of the survival rate among those who use television as a source of information. The public perception of the study participants was that the chance of surviving an in-hospital CPR event was 70%, 70. So if we compare that, we've got some significant expectations to meet from the public. When our patients and their families come in, we have to initiate CPR. Obviously, they're significantly expecting that we are going to be able to bring that patient back to life, when reality tells us that only 17% will survive to discharge. So I'm going to flip to our new focus because we have to swap that out. How many of you, by show of hands, how many of you work in an acute care facility? You work in a hospital, you work in a place where you have to take care of very, very sick people. A large number of us out there today. So right now, as you're in your facility, patient autonomy is a huge piece, right? The patient's ability to make his or her own healthcare decisions. You and the patient, you have that right as a patient, your patients have that right. They have the right to informed consent, which means that they have been explained all of the risks and benefits of those medical therapies, and they can decide based on that information whether they would like to accept or reject that therapy. We are under this treating all individuals with respect. We do no harm. Our acute care medicine focus is very individualized. Our public health focus is a little bit different. But why the change in focus? That's because we've encountered a situation in which our goals have changed. We are no longer focused on saving one life in one room in one hospital. Instead, we're tasked with effecting the greatest good in a larger situation. Hurricane, tornado, earthquake. We have to understand that our resources and time to effect a positive good are limited. So with the public health perspective, we have to swap our view. We have to look after the good of the community. And we're looking at this justice perspective or a fairness principle for the whole community. We know we do not have enough resources for everyone in our community. If everybody in your town showed up at your hospital at the same time, do you think that you would have enough resources to make that work? Probably not. And the downside, of course, is that our autonomy or our patient's autonomy is subverted because the public welfare is now the main goal. Now, we've got to remember that we're talking about major situations. We're not talking about next Tuesday everybody's going to show up at your hospital. What we're talking about are public health emergencies, natural disasters, and terrorist events. So public health emergencies include pandemic outbreaks like SARS, the H1N1 flu, multi-drug resistant tuberculosis. Now we're seeing epidemic, not quite pandemic, but epidemic levels of pertussis in some areas of the country. So we're looking at public health emergencies that are medical issues. These are communicable disease processes that can affect the whole community. Our natural disasters are, of course, things like earthquakes, hurricanes, tornadoes. Depending on what area of the world you live in is what issues you're going to have in that particular area. And for the sake of convenience, we're going to lump motor vehicle accidents, building collapses, and other types of mass casualties into that category as well. And then terrorism events can be in the form of a biological weapon or some sort of weapon of mass destruction. So let's talk a little bit more about our public health emergencies and think about this in the context of what's going on today. The Middle East respiratory syndrome coronavirus has been a big deal for the past year or so. The first 2 cases in the United States were identified in May of 2014. We haven't seen quite the outbreak that other areas of the world have seen, but this is still a disease process that can pose a significant public health emergency. Multi-drug resistant tuberculosis has been on the radar in Europe, in many places in Europe, for several years, mostly because of the usage of antibiotics. The population that's more exposed to this MDR-TB also has minimal access to physicians and a consistent source of antibiotics. So black market antibiotics that are sold on maybe the lower dose, fewer supply. You know, we know that too little dosage and too little time for the prescription taken gives the bug a little bit of an opportunity to become resistant to that antibiotic, and therefore we have an opportunity for that particular strain of tuberculosis to be multi-drug resistant. And we've seen that quite a bit. Severe acute respiratory distress syndrome, or SARS, has been an issue in years past. And then in 2008, 2009, we had the H1N1 flu epidemic, which of course was large in the United States, and in many parts of the country did pose a significant public health emergency. Now, natural disasters, of course, have been on the radar or on the news for the last several years. We've had some significant situations. Now, this is not a complete list, obviously, but these are issues that I wanted to bring forth as maybe an example of what you might face in your area of the world. Just this year, we had a Washington mudslide that claimed the lives of 41 people. It's interesting to think of a mudslide as this natural disaster, but that area was just devastated by this shifting of soil. In 2013, we had a couple of major typhoons. India had one in October of 2013 that claimed 50 lives. And in the Philippines in November 2013, about 6,000 lives were claimed. Again, these are major situations that produce a large number of people who need immediate care. Superstorm Sandy has a death toll of 285. The Japan earthquake and tsunami claimed over 13,000 lives and resulted in subsequent nuclear power plant damage, which continues to be an issue. Tornadoes in the Midwest are a major issue. The Joplin tornado in 2011 claimed 162 lives. Southern Illinois had a smaller tornado, but that claimed 7 lives and damaged a hospital there. In 2013, an Oklahoma tornado claimed 24 lives. We have the Haiti earthquake that claimed over 300,000. And then, of course, Hurricane Katrina, which was absolutely devastating to that region and continues to have lasting effects. The point here is that we have a life toll. We have individuals who are injured and need medical care, but we're also going to see large amounts of damages and recovery costs associated with these natural disasters as well. Many of us remember the September 11 attack in New York and in other parts of the country, and in addition to the wounded, dead, and dying, the environment was difficult to navigate. So first responders who were trying to get to survivors to get them some help were claimed as well as the ground shifted, the buildings collapsed further. So when we're looking at these events, we have to remember what's actually happening in that situation. The actual event itself, the safety of the first responders, the ability to navigate to the survivors if there are survivors of that event, and then the larger impacts from there. So let's look at those impacts. These events, even though they're all caused by something different, can result in the same basic impact. Initially, there's chaos surrounding the event, and the anxiety of those who have lived through it results in a panic that can be hard to contain. So we have a scarcity of resources anyway. I don't know about you, but all the hospitals that I worked in had a very limited number of supplies. You know, we stocked enough supplies to take care of the usual patients coming in. So if we have an influx of 4, 5, 6, 10, 100 times the number of patients we typically see, then we're going to have issues trying to care for those people. In addition, those with lower socioeconomic statuses may not have immediate access to health care. They may not have personal transportation. In these situations, it's unlikely that public transportation is working. The location of the hospital may be very, very far away from their dwelling, from their settlement, wherever they live in a city or in a rural area. Before I moved to Texas, I lived in rural Missouri, and the major hospital where I would have gone had I needed care was over a river. Well, if those bridges had gone out, there's no way I could have gotten to that hospital to receive care. So there are barriers just in getting persons from one place to the next. Persons with higher socioeconomic statuses may have financial reserves, where persons with a lower socioeconomic status will likely have all of their capital within the dwelling, within their environment that's been impacted by the event, whatever has happened. Also, healthcare workers may not go to work. By a raise of hands, how many of you have been in a situation at your work environment where perhaps there was a snowstorm and people couldn't come in, or flooding and people couldn't come in, some sort of an event that prevented other people from showing up to work? Yeah, a lot of people there. There have been some situations where I have slept in an empty patient room because my colleagues are either unable to get in, or they've been affected by whatever the national disaster might have been, by the regional disaster might have been. So the healthcare workers are going to be impacted by whatever this event is as much as everyone else. So people may not come to work. They may have issues with getting their family members taken care of. In listening to stories about healthcare workers who were involved in the care of patients in hospitals in Hurricane Katrina, it was very challenging for them. They wanted to evacuate their family. They wanted to be safe. But on the other hand, they had a hospital full of people who depended on them for care. So there are some issues with staff. The staff that are in the hospitals may be exhausted. They're overwhelmed. They've been working for 36 hours straight with a candy bar and a can of soda to keep them sustained as they work in these situations. So very difficult to rely on whether or not the healthcare workers can come in. Governments, if they are still intact, are likely not to function optimally, or in some cases even mildly effectively. The traditional routes of information transfer may not be working. So print, radio, internet, those ways of finding that information for the public and transmitting it to the public may be much more difficult. Now, the impact of these disasters are going to focus on specific groups of folks. Women, children and youth, the elderly, the minorities are more likely to be affected in disasters than others, mostly because of the displacement of large numbers of people. So if you remember Hurricane Katrina, a lot of the persons who were displaced from that disaster were taken to the Superdome. And the people in the Superdome now had this new community, this closed community of strangers, some of them with possessions, some of them without, some areas of public restrooms, some fresh water, some food. But that in and of itself had new risks posed to this specific population. Now they're in an enclosed area with questionable ventilation, not a lot of fresh water or food, and they are exposed to persons who have maybe communicable diseases or unfamiliar areas. There were a lot of reports of trauma and abuse within that environment to those vulnerable populations. So we're providing this situation and having a hard time managing it and keeping our people safe. So in the case of public health emergencies, we are trying to prevent the spread of illness to the general population. So now we're changing our desired outcome. The desired outcome switches from that individualized care and goes back to protecting the broader population. So again, our why in changing our desired outcomes is protecting the population. The healthier we keep the general population, the less crowded our hospitals become and the fewer people die of the illness. This is why we isolate our TB patients. There are mandatory procedures set forth by state and federal governments to protect the population from an outbreak. From an ethical perspective, however, we're talking about utilitarianism, finding the maximal benefit for the greater number of people. In our everyday lives, this is not a focus that would sit well because, of course, we're so focused on the individual. But during a mass casualty event, we have to save as many as we can in whatever way we can do it. Now, this does infringe on personal liberty. This is a drawback to using this utilitarian perspective in this situation. If I were a TB patient, I likely would not want to be isolated and away from the general population. But to make the broader, the better good for the broadest number of people, that's ethically supported under that statement. So going a little bit further into that utilitarianism, what we're really talking about is a reverse triage. By a show of hands, how many people are involved in triage in your emergency room? Is anybody out there doing triage? Yeah, a few people. So when we triage a patient, we're looking at how sick are you, and do you need to get an emergency department room before other people so that we can treat you emergently. When we're talking about triaging in public health emergencies or in mass casualty events, we're actually doing the reverse. What we're saying is we're going to treat those who can be treated first. We'll provide prevention measures to those who could see the greatest effect. We can help those who can be saved, and this is what we're going to have to do to maximize the use of our resources. So again, this utilitarianism dominates individual justice. So I want you to think about flu vaccine shortages. In 2008, there was a shortage of flu vaccines. I don't know if anybody remembers that. I remember getting the big email that says, because you're a healthcare provider, you get to have a flu vaccine. The Department of Health and Human Services put forth a priority list and categorized the whole country into 4 groups. The first group were people who maintained homeland and national security. The second group was providing those people who provide health care and community support services. The third are those who maintain critical infrastructure. And the fourth are in the general population. So if you were in the general population, meaning you didn't fit the other 3 groups, then you had to be chosen for a vaccination based on your age and your health status. We recommended that those with pulmonary disease, chronic pulmonary disease, have a flu vaccine. Young children had a flu vaccine, but you had to be prioritized based on your health. So when the Public Health Department did this, when the Department of Health and Human Services did this, they also engaged the public. So they needed public buy-in. They needed that stakeholder buy-in to make sure that this allocation model they were using was fairly distributed. They received more than 200 written public comments, and in all the meetings, stakeholders in the public identified the same 4 program objectives. A, to protect the persons critical to the pandemic response and who provide care for persons with pandemic illness, that's us. B, protect persons who provide essential community services. C, protect persons who are at high risk of infection because of their occupation. And lastly, protect children. Now, this is not without conflict, though. We're now putting, which is, again, antithesis to what we do, we're now putting the public good over individual rights. So those who are engaged in public health ethics will start by asking whose liberty may be infringed by this particular policy. A basic infringement on liberty does not make a major ethical conflict, but those infringements that are undue, disproportionate, or unjustified does make a major ethical conflict. So maybe it's a little more accurate to think of this public health paternalism, which we typically shy away from in our everyday emergency department and ICU environments. Maybe it's better to think of this as directed toward overall societal welfare. So again, public health policy is aimed at the community, and it measures its success by the improved population health and longevity. So while the risk to self is often the least politically acceptable reason for regulation, some paternalistic policies can be effective, like wearing seatbelts and wearing helmets if you ride a motorcycle. Now, the ethical challenges within using this utilitarianistic perspective within the mass casualty, again, I can't say it enough, that violation of personal autonomy, but also beneficence, or to do good. The good to the many trumps doing no harm or non-maleficence in the autonomy of the individual. This means that you and I, who are used to doing the most good for the most people individually, are going to feel a little bit of anxiety and conflict within ourselves because we're unable to help specific individuals. There's this justice and perceptions of fairness, again, an undue or disproportionate infringement on personal liberty is not appropriate within the ethical model we use to allocate care. So we have to be very, very cognizant of that. But when we talk about this allocation of very scarce resources, we're talking about the 3 ventilators for the 7 patients. We also have to take into account the prognosis of that patient. Who can benefit the most from that mechanical ventilator? How can this resource be most effective? So we've identified our problem. I have a lot of sick people, and I have very few resources. My utilitarianistic goal is to affect the positive good for the most number of people. So the question here is, what's my course of action? How do I allocate these resources to be most effective? Another major challenge within these public health ethics is that there's no universal code of ethics for public health. The specific professionals within public health, the epidemiologists, the statisticians, the health educators, they all have individual codes. But who gets to decide, or what is the universal code of ethics? We don't have that. We don't have the data behind it. We don't have the evidence behind it. And then our current structure of public health is problematic. Again, we don't have a lot of data. We don't have a lot of evidence to support these things. And of course, emergent conditions are emergent conditions. They're usually not predictable. And of course, within that group, if we have a group of 20 people, it is highly likely that we're all going to have conflicting values because of our own personal belief set. So there is a push, obviously, to make decisions in medicine on evidence. And so we'd like to think that we could translate that evidence-based decision-making to mass casualty events, these multifaceted emergencies. The benefits of using evidence to make these decisions is that it can help us focus on outcomes that are reasonably predictable, and it attempts to remove some practitioner bias. It would be nice if we had an objective document that spelled out step 1, step 2, step 3, always do these things in this situation. That takes the burden right off of us, and that would be a very welcome addition to our tools for decision making. But again, we go back to that overridden individual liberty, and you and I and the rest of the healthcare team have to switch gears. We have to change in our mind how we view our role in that situation. I would imagine that most of us would instinctively run to the most seriously injured person, regardless of situation. But now we're switching that to a different outcome. And again, we just have a very weak evidence base. So even if we were to have that kind of a document, the evidence is so very limited in that situation. So there are some models for decision making, and we could argue these models for a few days, so I'm just going to go through them quite quickly. But this is these are a few of the models that are out there to make a decision in an ethical fashion, logical fashion, in a multifaceted emergency. The first is a random selection, a lottery, which sounds kind of nice, but you know, not everybody's going to show up to your door all at once and grab a number. So it's a little impractical for a decision making in an emergent situation. Now the first come first served model is supported by the American Medical Association. The quote states that a first come first served approach or some other equal opportunity mechanism should be employed to make final allocation decisions. However, I'll talk about a study here in a minute. These folks identified the first come first served model as favoring the wealthy, because the wealthy have the personal transportation and the resources to arrive at the care center earliest to use up those resources before those who are of lower socioeconomic status and don't have the resources. It takes a while for them to actually get there. The sickest first is how we currently treat, medical condition. We triage for the sickest first, bring them in. The downside to that, of course, is that we would use up a lot of our resources on a very, very sick patient that could have instead been allocated to minorly sick people, and we could have saved 5 or 6 people with the resources it took to treat and potentially save the one very sick person. Other models suggest having the youngest first because we would save the maximum number of life years on the back end. If we save all the children, then they have more years to be contributing to our society. Maximum number of lives saved, that would be our utilitarianistic perspective here, the maximum good. And some folks talk about maximum number of life years saved, so not just the sheer number of people saved, but that the people actually have quite a few life years. So going back a little bit to this concept of reverse triage and allocation, I don't know if anyone has seen the movie Pearl Harbor. It came out in 2001. It's kind of an older movie. But there's a scene in this movie, if you haven't seen it, I would encourage you to watch it, at least for the scene, that depicts what happened at the hospital at Pearl Harbor when the attacks began, and how the hospital that was very, very slow, didn't have a lot of patients in there, quickly became overwhelmed. And in this picture, what we see is one of the main characters having to triage out in the parking lot on the sidewalk the men who were coming in who were injured. The men who could be saved were moved into the hospital. The men who were critically or mortally wounded were moved over under a tree so that they could die peacefully under a tree. And the allocation model used in this particular scene was the maximum number of lives saved. They were trying to use the resources for those people they knew they could save. In 1981, one of the deadliest building collapses in the United States happened in Kansas City at the Hyatt Regency when the skywalk collapsed. 114 people perished in this collapse, and there are a few pictures from the debris there. I went to a conference a while back where one of the first responders was recalling the event, and he said that it was very difficult for them to switch that mindset from the individual to saving the maximum number of people because there were so many critically ill people buried under debris, trapped under debris, that they knew were fatally wounded, and they had to get the maximum number of people out of the facility before they could start to put their resources towards those who were more critically injured. So who should make these decisions? There are a lot of issues out there with developing a guide or a strategy to making allocation decisions, and it was decided that in addition to not even knowing who should make these decisions, but how they're going to make these decisions, this group, Cao and Wang, did a simulation study in 2010, I believe they published, and what they did was they simulated the 2008 earthquake in China that claimed an extraordinary number of lives and injured a great number of people. And of course it's a simulated casualty because we can't study these within the model itself, within the event itself. But what they did was in the simulation, they evaluated the outcomes based on the application of 4 different models. So they ran the simulation and they applied the first come, first served to see the outcome. Did the same with the random selection, the lottery, the most serious first, and then the least serious first. Now, the authors freely admit that these findings may not be generalizable because of the nature of the event they studied, the geography of that area in China, the population density, and then the community infrastructure, what was available to those people at the time. And what they found was that treating the least serious person first resulted in the fewest deaths within that situation and used fewer resources for those with the best chance of survival. What they also found was that even though this had the best outcome in regard to saving the most people in that situation, it was also the most ethically challenging for the providers to deal with. So next, random selection, then it was a first come, first served, and then treating the most serious victims first resulted in the most deaths within that model because it used the most resources for those with the lowest chance of survival. But this was the instinctive option that the rescuers clung to. So I don't know that this really surprises us based on our previous conversations, but even though treating the least serious persons first promises a higher efficiency and improves our outcomes, it does go against how we practiced in a normal day. Now, ethically speaking, without dealing with the inner turmoil, the least serious first model is the most ethically appropriate based on these results. So what are the public concerns? The AHRQ did an evidence report in June of 2012, and they looked at the allocation of scarce resources during mass casualty events. One of the key questions that was asked was, what are the public's concerns regarding strategies to allocate scarce resources? They identified 10 studies that they could pull this relevant information. Though the studies do have limitations, they were all well designed and had about a medium strength of evidence. So summarizing these studies, a successful system should balance the goals of ensuring the functioning of society, saving the greatest number of people, protecting at-risk populations, reducing deaths and hospitalizations, and treating people fairly and equitably. And again, the public really had a strong feeling about the fair and equitable treatment of the persons who arrived for therapy. Participants used multiple criteria to prioritize recipients during a mass casualty event. Healthcare professionals, healthcare workers, and first responders were among the highest priority groups for therapies, for treatment. Interestingly, politicians were among the lowest. Many who responded to these surveys accorded high priority for children and young adults. Most of them rejected prioritization criteria based on ability to pay, and first-come, first-served models, and lottery models. The public showed high faith in medical professionals, and resource allocation guidelines should be generally consistent, but should allow healthcare institutions some degree of flexibility to make allocation decisions based on their specific demand and supply situations. So what about these strategies? Well, there are two different kinds of strategies. One is a push strategy and one is a pull. A push strategy is a strategy that distributes medications and aid directly to households. A pull strategy is bringing patients in. So you can see where a push strategy would be better because we're keeping the relatively healthy, relatively unaffected people in their home environments versus pulling them all into a central location, which could increase their risk of getting hurt, increase the hospital's ability to, or decrease rather, the hospital's ability to care for that number of people. So not a lot of evidence, but it does make sense that a push strategy would work better than a pull strategy. And that could include things like distributing surgical masks for particulate, if there were a particulate in the air that we wanted to protect people from, like crushed concrete or something. It could also mean self-quarantine. You know, keep yourself at home if you're healthy so you're not exposed to whatever else is out there. Mass distribution of biological countermeasures reduces the demand for healthcare resources. So if there was some sort of a vaccine that could help with whatever communicable disease is being passed around at that point, visiting a person's home and distributing vaccines in that fashion may be better, again, than pulling people in. Again, not a lot of evidence to support these things. Also, resources can be managed by load sharing, which is transferring patients to other hospitals, more distant hospitals, opening a temporary facility, those kinds of things. But again, you know, there's some issues with the evidence that supports these. Now, some states have made progress toward adopting plans to manage and allocate resources under crisis standards of care. Most, but not all, have described strategies that fit into one or more of these four domains. First is reducing demand of scarce resources. Second is optimizing the use of existing resources, maybe distributing the vaccines that we have or surgical masks, those kinds of things. Augmenting the existing resources, and then implementing crisis standards with standards of care based on predefined priorities with the understanding that some patients may receive comfort care instead of aggressive intervention. Again, however whatever model we're using for that. To date, though, no state disaster plan includes all four of these domains. And at the time of publication of this AHRQ document, there was no literature to back up a crisis standard of care. So to summarize, ethics is how we should act in consideration of others, not how we feel or believe. Again, remember that ethics is that analysis of the societal morality, of the group morality, of the individual morality. Multifaceted emergencies shift the focus from individualized care to considering the good for the community. Again, we're back to that utilitarianistic perspective where we maximize net benefits, the greater good for the greatest number of people. And there are multiple allocation models, but no real evidence to be able to generalize one model for all emergencies. And here's a list of my references. If you're interested in this topic, I do recommend the AHRQ 2012 executive summary. That provided a lot of really great information that could help influence how you do your respond in your situation, or help you with making perhaps a system for your own hospital. So with that, I will open it up to questions.
Well, thank you very much, Shawna. That was a wonderful presentation, and we do have a handful of questions and would certainly welcome any more that you might have. One of the first questions that popped up just within the first minute or two of your presentation when you talked about the mechanical ventilation dilemma that you described with some of your undergraduate students, and one of the comments was, so 3 people of the 7 will get mechanical ventilators. Are we just supposed to assume that or accept that the other 4 people are going to die? And it's a psychological issue. It's an issue that if you look at what physicians do when they become doctors, take the Hippocratic Oath of doing no harm. You know, it's such a huge dichotomous approach to how we've always done it. Do you have any recommendations or issues on how to deal with that psychological component of just allowing those who are not going to be able to serve knowing that they're going to die?
That's a really difficult question, and it's a great question. To answer the first part of which of only 3 of the 7 will live, you know, the situation in which I put those students was a little bit loaded, because in the real world, yeah, we would not have just said, okay, those other 4 will die and that's the end of it. You know, let me find the coroner here. That in the real world, we would have identified of those 7 people, which ones maybe, especially if we were using the principle of least serious first, we would have identified which of those patients had the best chance of a positive outcome if we put them on mechanical ventilators. And the situations that I gave the students were a couple of little kids, a set of twins who had really bad flu. I had an elderly lady who was in her 80s, and she had a really bad pneumonia, and she had rejected the idea of mechanical ventilation, but her daughter, who was a lawyer, was pushing for mechanical ventilation. So I threw a few curveballs in with these. But the point for the students was to identify, I would allocate based on this model. I would allocate based on least serious first, or age, or severity of disease. I was making them choose, critically think through the situation and choose which model they felt was most ethical. In the real world, we would have done that, and then we would have gone to the other 4 patients to see how else we could suit their needs. Could we use a non-invasive ventilator? Could we use a transport ventilator? Could we drag that old dirty PR2 out of the basement or out of the NICU where we've been using it for bumpers to stimulate those little newborns to breathe every now and then, and ventilate the patients that way? But you're right, psychologically, this is a very difficult time, especially if we've never had to deal with this kind of reverse triage concept. I noticed that one of the persons who chatted in the room mentioned that this reverse triage is how the military triages. So someone who's been in that situation before, I'm not going to say will have an easier time of it, but maybe better prepared to deal with that than those of us who have never had to do that and never had to make that decision of this person will receive care, this person will receive comfort measures, and allow that person to pass because we don't have the resources. A lot of the hospitals and healthcare facilities that I have spoken with over time have indicated that as part of their training for these situations, if it happens, they're including staff counseling to help them accept in these situations they're doing the best they can with what they have and how to deal with that.
Fantastic response. We had another question. Once again, it was somewhat early in the presentation, and one that I think that you somewhat answered, and it was, how are these decisions being made? Is it an individual? Is it a group decision? Is there a tool that we use? And to kind of summarize the question and maybe make it into a more neatly packaged question for you, if our members or the attendees on this webcast today, if their hospital doesn't have a triage policy to address some of these issues, do you have any words of encouragement or opportunities on how they can begin that process?
Well, what I would recommend if, first of all, the majority of facilities who have these kinds of policies or who at least have a game plan in effect have a multidisciplinary approach. So they're pulling someone from the respiratory care department and nursing and physicians and building services. How is the building going to handle this? And maintenance and the IT department. So everybody within that hospital is a stakeholder. Every department, whether it's as high up as the C-suite versus the people who do the day-to-day jobs, all of those people have an invested interest in what happens in that scenario. So the hospitals who I've seen work with really great and encompassing policies start by bringing all stakeholders to the table and starting with the question of, if we had an influx of 10 times the patients we have now or 100 times, what problems are we going to have? And then working through those problems to figure out a pathway. A lot of the hospitals that I've talked to about this have had training events where they have a critical event, a mock code or a mock community event. Has anyone out there participated in one of those mock community disasters? They get everybody involved. Yeah, a lot of folks. They get a lot of people in the community involved. In my hometown, the high school got involved, and they were the actors. They were the people who were all made up to look like they had been in a disaster in this area, this predetermined area, and then the first responders would come in and they would do their drills. The first responders would then take them to the hospital, and the hospital people would do their drills. So there is a lot of not only policy planning, but also ongoing education and training that's very important to make sure that your people are up to snuff so that when something happens, they're not saying, oh, well, we have this random policy, but I read it once, or I did a continuing education event about this, but I don't really remember anything else about it. So this ongoing skill set is really, really important. There are also state and national disaster plans, and again, states are going to vary from time to time. So, you know, I would recommend reading through that, because a lot of the states have strategic national stockpile. Well, we have the strategic national stockpile of ventilators with the CDC, but some states have also identified that they wanted to have some sort of mechanical ventilation stockpile to distribute to hospitals as surge capacity as they have the surge capacity. So, you know, knowing what ventilators are going to come to you if you are the recipient of one of these state pods, what ventilator are they going to bring to you? Do you know what you're going to get when you open the box? Is it going to be a ventilator that you're very, very comfortable with and you use in your facility, or is it a ventilator that you haven't seen in 15 years and you could probably run it, but it's going to take some time, versus some machine you've never seen before and you're going to try to figure out how to ventilate that patient at the last minute? So I would definitely read the state disaster plans, and then I would do a search for who's doing disaster preparedness planning and see what kind of networks you can get.
Well, thank you, Shawna. We had some other questions involved, but unfortunately I think our hour allotment here has wound down today. I'd certainly like to thank you for joining us today, Shawna, and delivering this fantastic presentation. For those of you watching this as a live presentation, please stay with us during the next brief pause for instructions on how to obtain your CRCE contact hour. If you are watching this program as an archive, this concludes our presentation. Shawna, thanks so much for spending your hour with us today.
Thank you very much, Doug. I appreciate it.